Good
Okay.
evening, everyone. This is the weekly scientific meeting of the Oman Society of Nephrology and Transplantation, and we are continuing the pediatric nephrology sessions. In fact, the pediatric nephrology team is very active this month. We are presenting our thanks and gratitude to their continuous activity. Today we have a special guest, the Professor Bassam Saeed from Syria. He's a senior consultant of pediatric nephrology. Will present two talks, and the moderator of this session will be Dr. Badriya Al-Ghais, senior consultant pediatric nephrology in the Royal Hospital. So, Dr. Badriya, the floor is yours to introduce Dr. Bassam.
أيوة شكرا دكتور. So on the behalf of the organizing committee, I would like to welcome Dr. Bassam Saeed, and it is a pleasure to have you with us, Dr. Bassam, this evening. Dr. Bassam is a pediatric nephrologist consultant, and he's a president and founder of Farah Association for the Child with Kidney Disease in Syria, and he's a chair of the ISN Middle East Regional Board. He was president of the Middle East Society for Organ Transplant. Dr. Bassam is going to talk to us tonight about long-term management of pediatric kidney transplantation, and then he will give a highlight on pediatric kidney transplantation in the Middle East, challenges and solutions. So welcome, Dr. Bassam, again, and the floor is yours.
Thank you very much, Dr. Badriya, for your kind introduction. First of all, I would like to thank the Oman Society for Nephrology and Transplantation for the kind invitation. It's an honor and pleasure for me to be your guest in this important webinar. Many thanks to my dear friend, Professor Isa Salmi, for the kind invitation, and Professor Sulaiman Saidi, and also, of course, Dr. Badriya and Dr. Saja. So I will talk about long-term management of pediatric kidney transplantation. So as you know, the goal of kidney transplant in children is to provide a duration and quality of life similar to their healthy peers. Pediatric kidney transplant recipients are distinguished from adult by many things. Number one, the need for many decades of graft function, up to 5 or 6 decades. The potential effect of CKD on neurodevelopment, unlike what happened in adulthood. And the changing immune environment. We will be talking about this point later on. This is a high-risk period of adolescence. It's very important to know about. All pediatric transplant recipients must pass through the high-risk period of adolescence where graft failure rate are higher than any other age. The usual challenge of emerging adulthood: number one, transition from school to work; number two, romantic relationship, as you know; and three, achieving independence from parents. So what are the factors that contribute to the high graft failure rate in adolescence? Number one, poor adherence, we'll talk about later on. The transfer of care from pediatric to adult-oriented care providers, and the increased potency of the immune response during adolescence. What are the benefits of kidney transplantation over dialysis? There are so many benefits, of course, as you know. The life expectancy benefit of transplantation over dialysis may be as much as 25 to 30 years. Pediatric transplantation show, number one, superior growth compared to those who remain on dialysis, improved neurocognitive development, better academic performance, better quality of life, in fact, better everything. However, there are many challenges when the child receives a transplant. What are the challenges? Number one, to maintain graft function. This is the hope for every pediatric transplant. We hope that to live around 50 years of graft function. The vast majority of pediatric patients will require more than one transplant during their life. Very small pediatric recipient, those below the age of 4 or 5 years, must successfully perfuse an adult donor kidney, which must accommodate large changes in body size. Viral infection, especially CMV, EBV, and polyomavirus, may have more severe consequences in infection-naive pediatric patients. And as you know, most of the small pediatric recipients, they are infection-naive. They still are not infected with these viruses. Pediatric transplant recipients must get into or through two high-risk intervals. Number one, the early post-transplant period during taking the highest dose of immunosuppression. And number two is the adolescence, during which immunologic risk may be heightened and medication adherence may be suboptimal. What are the characteristics of pediatric kidney transplant recipients? Most transplant programs require infant to reach at least 10 kilograms before considering transplant. Some program transplant baby as small as 6 kg. But as far as I know, in the Middle East, we are transplanting children above the weight of 10 kilograms. The majority of pediatric transplant recipients are adolescents. A substantial fraction are under the age of 5 years. A greater proportion of pediatric transplant recipients are male than female. I don't know why. The primary kidney disease in children are different from those in adults, of course. As a substantial minority of pediatric recipients have congenital syndrome associated with other conditions in addition to kidney disease. Now, look at this comparison of international pediatric kidney transplant recipient characteristics. As you can see here, we have studies from United States, from Europe, from Australia, and United Kingdom. It is somehow different, especially with regard to allograft survival and kidney diagnosis. For example, here, CACUTE, which is congenital anomaly of kidney and urinary tract, represent the vast majority of the end-stage kidney disease in children in all countries. Regarding the allograft survival from deceased donor and from living donor, in the United States, 83%, 5 years, and 61%, 10 years. If we look at Europe, 90%, 5 years, 77%, 10 years, etc. We don't have time to go through all this. There are some unique considerations for pediatric kidney transplant recipients. We have to look for a primary disease and the effect of kidney failure on neurodevelopment, age-related differences in immune function, especially during adolescence, and viral infection risk. Also, age-related behavioral issues, transplant timing within the life course, and transfer from pediatric to adult-oriented care. And lastly, which is also a very important point, which is the adherence. We'll talk about it later. Now, what about the primary disease? Bladder abnormalities are very common in pediatric patients with end-stage kidney disease. The majority of pediatric kidney transplant recipients have congenital anomaly of the kidneys and urinary tract. A substantial subset of patients have bladder abnormalities. Lifelong bladder dysfunction requiring ongoing urologic care. With poor bladder emptying most of the time, therefore, there is a high risk for UTI and obstructive nephropathy. Many have hydronephrosis of the graft leading to interstitial fibrosis. Therefore, the need for intermittent catheterization. Oxybutynin may be prescribed to improve spontaneous bladder emptying. Intermittent of bladder function with urodynamic is necessary in those patients. Now, what about patients with inborn error of metabolism? Especially cystinosis or primary hyperexaluria and methylmalonic acidemia. The patient with cystinosis, they require lifetime enzyme therapy. Primary hyperexaluria type 1 and methylmalonic acidemia preferentially treated with combined liver and kidney transplant. What about FSGS? FSGS is the cause of kidney failure in 10 to 14% of pediatric kidney transplant recipients. Unfortunately, there is high risk of recurrence in idiopathic FSGS. Recurrence commonly leads to graft failure and little hope for successful repeat transplant. Even if we retransplant the patient may recur FSGS again on the graft. What about atypical HUS? Atypical HUS frequently recurs post-transplant, unfortunately. Eculizumab therapy, fortunately, has improved the outlook for these patients. But this is a very costly, a very expensive medication and require lifelong therapy, unless if there is some help or support from the government. For children with multi-system disease, multidisciplinary care is necessary. What about the effect of kidney failure on neurodevelopment? Children with kidney failure are at high risk for abnormal neurodevelopment. The younger the child, the higher the risk of cognitive impairment. Compared with healthy children, a proportion of pediatric kidney transplant recipients show low average intelligence range. Academic performance is often poorer than in healthy peers. Memory deficit also may impair medication adherence. This is one of the reasons for their poor adherence. What about the age-related differences in immune function and viral infection risk? Young infants, as you know, have an immature and less robust immune response. This permits greater tolerance of transplanted organs. However, it also puts them at high risk of infection. So this point protect them from one part from organ rejection, but it exposes them to higher risk of infection. Young pediatric transplant recipients are less likely to have been exposed to important viral illness and are less likely to have immunity to these viruses. The risk of EBV viremia are highest in EBV naive patients, and most of those small children are EBV naive patients. So when they receive transplant from EBV positive donor, which happens in 40% of pediatric recipients, EBV viremia is of particular concern because it is associated with high risk of post-transplant lymphoproliferative disease, PTLD. What about the transplant timing within the life course? Short stature is common and may negatively influence self-esteem. Academic and employment prospects may be permanently altered. Social development and independence from parents are often delayed. The child or the adolescent remain dependent on his family for longer time. Romantic relationship may be delayed or impeded. Social isolation owing to illness is common. High rate of depression and anxiety. A multidisciplinary approach is particularly important. Psychosocial support throughout the transition process with mental health screening. So what about the transfer from pediatric to adult-oriented care? We have to look at 2 points, the care environment and the age-related risk. The care environment, whether the patient is being cared by pediatric nephrologist or by adult nephrologist. The transfer typically takes place at around 18 to 21 years of age, sometime below this age. This period is peak graft failure risk. Other factors associated with the heightened graft failure risk observed during adolescence and young adulthood because of poorer medication adherence and because of enhanced immune potency during this age. It is possible that the higher risk of graft failure observed after transfer simply reflect age-related risk rather than any real effect of the care environment. Some may say that because the patient was shifted to adult care, the patient is having problem, graft failure, etc. But sometimes it is related not to the transfer, but related to enhanced immune potency. So the age of a transfer. There is some evidence that the risk of graft failure after transfer depends on age at transfer. A study of 440 American transplant recipients found a 57% higher risk of graft failure among recipients transferred at 21 years of age compared with recipients of the same age transferred below the age of 21 years. So if we transfer below the age of 21 years, according to this study, it would be better. The major concern is that adult care setting may not adequately support adherence to medication, in contrary to pediatric nephrologists, because pediatric nephrologists will always concern about this point. Pediatric care tend to be more family-focused, whereas adult-oriented care tend to emphasize the autonomy of the patient. Involvement of a supportive parent may be the single most important factor in successful transition. Even if the patient is shifted to adult care, the parent must continue their supervising role. There are numerous risk factors for poor adherence have been identified. However, our ability to predict adherence is poor. It is important that adherence be assessed regularly in all patients. Adherence assessment include, number one, self-report tools. Although it is believed to overestimate adherence, it is highly feasible. Variability in trough level of tacrolimus may push us to suspect about poor adherence, because if you usually monitor tacrolimus and the patient is getting the same dose, but the tacrolimus level is much different, we have to suspect that the patient is not getting his medication properly. Also, there is electronic monitoring. What about the guidelines for transition from pediatric to adult-oriented care? In 2018, the Organ Procurement and Transplantation Network provided guidance on critical milestones for patients to achieve before transfer to adult care. This is a critical milestone for adolescents, young adult before transfer to adult care. The child or the adolescent, before going to the adult care, he should be able to do all this. Number one, describe original cause of their organ failure and need for transplant, and to be aware about the long and short-term implication of transplant condition on overall health, like infection, cancer, vocational aspirations, etc. They should be aware also about the effect of illness on sexuality and reproductive health, and they should be having the sense of responsibility for their own health care and capacity to provide most self-care independently, and be able to express readiness to move into adulthood, and ownership of medical information in a portable, accessible summary. They may have with them all the related information regarding their disease. So all this must be available, must be ready before we decide to shift the patient to adult care. Guidelines for transition from pediatric to adult-oriented care. It is a multidisciplinary approach to transition is very helpful. Input from social work is also important. Adolescent medicine, pharmacy, and financial counselors. We may take the opinion of all these parts. Referral for psychological counseling may be helpful sometimes for patients experiencing particular difficulties. We are not doing this for all patients, but for some patients, we may need to refer the patient for psychological counseling. Transition to adulthood and independence continue after the transfer of adult care. This means that if the patient was transferred to adult care, this doesn't mean the transfer process finished. We have to continue looking at the other issues. The most successful transition program include ongoing support for young people even after transfer, recognizing that this is an interval of high risk. This is the, as you can see here, pediatric to adult transition process. We have different process. Number one here, when the patient is under pediatric focused transplant care, usually before the age of 12 years. The transition process, middle transition from 13 to 15 years, late transition after the 16 years. But when the patient will become in adult focused, must be after the age of 21 years. As you can see here, during the pediatric focused transplant care, the parent are manager. Okay. The middle transition to 13 to 15 years, the parent are supervisor. They are not manager. They are supervising their children, whether they are taking the medication properly or not. Late transition after the age of 16, the parent are consultant, and same after shifting to adult care. So pediatric renal transplant recipients are distinguished from adult recipients by different distribution of primary kidney disease, number one, the potential for developmental sequelae of kidney failure, and the need for many decades of graft function. And most importantly, all pediatric recipients must pass through a period of high risk for graft failure, which is adolescence and young adulthood. So potential contributor to high risk period of adolescence and young adult, number one, enhanced immune activity during adolescence, and age-related reduction in adherence to treatment, and decline in adherence related to transfer from pediatric to adult care. How to mitigate this decline in adherence in young adulthood? We need, number one, universal immunosuppressive medication coverage. This will help a lot. Number two, understanding of the challenges faced by pediatric recipient will aid both pediatric and adult care provider in supporting young recipient across the lifespan. We have to understand the challenges faced by pediatric recipient. We as pediatric nephrologists, we understand this, but when the patient is shifted to adult care, we need to make sure that the adult care also provide supporting young recipient across the lifespan. Future research for improving long-term outcomes could focus on effective ways to partner with adult care providers. Thank you very much. Now I will move to my second part, unless if you have any comment or question, etc.
What do you think, Dr. Bassam, regarding the use of belatacept for non-adherence for adolescent patient, because it can be given intravenous, especially in the adolescent with the positive Epstein-Barr virus serology, less risk for PTLD.
I have no experience about this in order to respond to your question in evidence-based medicine. I have never seen I have never applied this way to protect the patient from PTLD.
Yeah, this is the one of the option for adolescent if we have the medication. So in some center, they may be used for adolescent non-adherence to prevent rejection and lose of the grafts. So one of the medication which can be used in the future to prevent rejection in high-risk adolescents. Thank you.
One of the things that also we can...
I think we'll proceed with the second part of the presentation, then we'll have questions at the end.
Okay. So we'll move now to pediatric kidney transplant in the Middle East, challenges and solutions. As you know, in developed countries, pediatric kidney transplant has become a routinely successful procedure where 1 year graft survival exceeds 99% from living donor and exceeding 97% from deceased donor. Regarding the 5-year graft survival exceeds 90% from both living donor and deceased donor. So excellent result regarding 1 year or 5-year graft survival. This outcome, of course, are a cumulative effect of 3 decades of improvement in dialysis procedure, improvement in surgical technique, in immunosuppression, in diagnosis and treatment of rejection, and effective control of infection. In contrast, developing countries have poorly developed pediatric kidney transplant program. There are so many reasons for this, especially poor economic indications, low governmental expenditure on health, and underdeveloped renal replacement therapy for children. Now, what about the burden of pediatric CKD? The incidence of CKD in children remain largely unknown in the developing world. Generally, children are referred late, where 24 to 63% present already in end-stage renal disease, up to 63%. The reason for late referral are, number 1, neglect, number 2, long distance from the tertiary centers, and economic constraints. What about the rates of pediatric kidney transplant in developing countries? Overall, kidney transplantation rates are low in developing countries, mainly due to economic and paucity of facilities, as I said. In children, kidney transplant rates where reported are low. Most reports are single center experience, except a few multi-center report. This is a number of studies on pediatric kidney transplantation from Middle East countries that I've collected. As you can see here, the name of the country and number of transplanted patients and during of follow-up and the year of publication and reference in which journal. As you can see here, Algeria, Egypt, Iran, Jordan, Kuwait, Oman, Pakistan, Saudi Arabia, Sudan, Syria, Turkey. This study aimed, I did already, aimed to collect data on the volume of pediatric kidney transplant from Middle East countries. All well-known Middle East kidney transplant center and or national kidney transplant societies from across the Middle East were contacted. I contacted them personally to answer specific questions related to both adult kidney transplant and pediatric kidney transplant from living and deceased donor that were performed in each country during a recent year. I couldn't collect data for one single, the same year, but one recent year. I mean, either it is 2019 or 2020 or 21. We will see the details later on. We did receive the requested data from all Middle East countries, except, unfortunately, Bahrain and Oman, because no recent data were available from these 2 countries. Recent data, no recent data. In this report, we have an overview of pediatric kidney transplant in Middle East country, as well as challenges encountered and their solution for establishing successful and viable pediatric kidney transplant program. Sorry for this busy slide. As you can see here here's the countries, as you can see, all the countries, the population of all these countries, and the year the data collected. And here we can see the all ages transplant, adult and pediatric. Unfortunately, and I cannot see the whole screen here. Some technical issue. Anyway, altogether, as you can see here, altogether, the total kidney transplant, 8,484, which means kidney transplant per million population, 10.6, and 10.6 kidney transplant per million population per year. The number of deceased kidney transplantation, 1,211, which means 14.3% of all transplants were from deceased donor. Now moving to pediatric, which is our important point. Pediatric kidney transplantation, the total was 746 pediatric kidney transplantation, which makes the rate pediatric kidney transplant per million population 0.93 kidney, less than one pediatric kidney transplantation per 1 million population, ranging from 0.1 to 3.2, different between countries. What about the pediatric share, which means the percent of pediatric over total transplant? Average was 8.5%. The deceased pediatric kidney transplantation, we have 136 deceased pediatric kidney transplantation, which means 20% of all pediatric kidney transplantation. Now, this is the total versus pediatric kidney transplantation. As you can see here, the highest number in Turkey, 3,371, 242 in red color for pediatric recipient. We can see all these countries. So the total kidney transplant in the Middle East in 1 year, 8,484 kidney transplant, pediatric kidney transplant, 746 pediatric kidney transplant in one single year in the whole Middle East country. This is the total kidney transplant in the Middle East per million population. This is per million population, because if we want to know the efficacy and the volume, we should look at per million population, not the total, because the population of each country is different. You can see here Turkey is number one, 39.7 total kidney transplant per million population, followed by Iraq, then Syria 19.2, my country, Kuwait 18.7, etc., etc. So the average in the whole Middle East was 10.6. So 10.6 kidney transplant for all ages per 1 million population per year. Now, what about the rate of kidney transplant in the Middle East countries, total versus pediatric? This is the studies that I just mentioned. The whole population of the Middle East was 801 million. Total kidney transplant, 8,484 total kidney transplant. The rate was 10.6 per million population. The pediatric, as you can see here, we have 280 million pediatric population. The total pediatric kidney transplant was 746, which means the pediatric share 8.5% of the total. The kidney transplant rate per million population is 0.93, less than 1, but this is for the total population. If we want to calculate it per 1 pediatric million population, not the total population, the pediatric population, it will be 2.7 pediatric kidney transplant per 1 million pediatric population. Now, if we wanted to compare this result with what happened 10 years ago or more than 10 years, as you can see here, the population was, of course, less, but the kidney transplant rate 10 years ago was almost a little bit higher, 11.8 total kidney transplant per 1 million population, compared to recent year, 10.9. What about pediatric? 10 years ago, the rate of pediatric kidney transplant was 0.87, a little bit less than what is going on now. So regarding pediatric kidney transplant, we are doing a little bit better than 10 years ago. Now, this is the pediatric kidney transplant in the Middle East per million population. My country, has the highest rate of pediatric kidney transplantation. As you can see here, 3.2 pediatric kidney transplant per million population. The average of whole Middle East was less than 1.93. This is a per million child population. This is total population. This is per child population. The average was 2.7 pediatric kidney transplantation per 1 million pediatric population per year. Now, sorry. This is international versus Middle East. Pediatric kidney transplantation internationally, as you can see here, Spain is #1, followed by Finland, US, etc. This is the Middle East. The Middle East, as I said, here, pediatric kidney transplantation, the average was 2.7. What about deceased donation for pediatric recipient? As you can see here, in countries where we have red color, means that these countries, we have deceased donation program. Regarding those countries where we don't have red color, means that the transplantation dependent only on living donor. Here in this country, for example, in Tunisia, 6 pediatric kidney transplantation in 1 year, all from deceased donor in Tunisia. That's the reason why 100% of the transplantation in pediatric in Tunisia, all from deceased donor. Regarding United Arab Emirates, as you can see here, 79% of pediatric kidney transplant from deceased donor. In Kuwait, 75% from deceased donor. In Iran, 75% from deceased donor. In Qatar, they have transplanted 2 pediatric patients, one from living donor and one from deceased. Saudi Arabia, 14% from deceased donor, and Turkey, 23%, 2.3% from deceased donor. Now, this is the total. Living versus deceased donor pediatric kidney transplantation in the Middle East. As you can see here, the total is 20% of all pediatric kidney transplant are from deceased donor, 80% from living donor. This is the whole Middle East. But if we look at what happened 10 years ago, in 2008 up to 2011, 15 years ago, we see here that at that time, 9% of pediatric kidney transplantation are from deceased donor. So what happened lastly, a few years ago, this percent almost doubled from 9% 10 years ago up to 20%. So nowadays, we have more deceased pediatric kidney transplantation. This is a good result. This is a pediatric kidney transplant in Middle East from 2019 up to 2021 in 1 year. The average in Middle East, this is the share, the percent. The percent, as you can see here, in Algeria, 20%, in Iraq, 3.2%, which means that in Iraq, only 3.2% of the total transplant go to pediatric recipient. The average is to 8.5%. So average in the Middle East, 8.5% of the total transplant is going to pediatric recipient. We want to compare our result with Europe. This is a study from Europe, as you can see here, but it is a little bit old, in 2004. In Europe, the average in European children is 4.57% of the all transplants are going to pediatric recipient, but probably because they have less pediatric population per 1 million population. In our region, we have more children. We are more producing children than European countries. This is my own explanation for this. Now moving to the challenges, pre and post-transplant challenges. Regarding the pre-transplant challenges, etiology, delayed referral, comorbidity, dialysis, donor issues, technical expertise, we will go through it. So pre-transplant challenges. Number 1, etiology of end-stage kidney disease. These are several studies that I collected from a different country, like here, for example, Pakistan, Turkey, and compared with North American Pediatric Kidney Transplant Cooperative Study. I noticed here that in Pakistan and Turkey, which are part of the Middle East, the unknown cause of end-stage kidney disease in pediatric patients are of unknown reason. Almost half of the patient in Pakistan, 38% in Turkey, compared to only 6% in North America and 7% of Europe, ERA EDTA. So this is one of the challenge in our region, Middle East, that the etiology of end-stage kidney disease in most of the time, not most of the time, up to 50%, for example, in Pakistan, up to 38% in Turkey, are of unknown etiology. So this is one study that I published a long time ago about the major causes of chronic renal insufficiency in Syrian children. As you notice here, that 56% of our patients having obstructive nephropathy. More than half of the patient, 56% obstructive nephropathy, which means that we are talking about delayed referral. Otherwise, those with obstructive nephropathy should not reach end-stage kidney disease easily. Comorbidities, we have so many comorbidities in pediatric patients with end-stage kidney disease, especially poor nutritional status, poor left ventricular function, anemia and multiple blood transfusion, hypertension, diabetes, infection, severe bone disease, oxalosis, HUS, etc., etc. So we have so many comorbidities in pediatric patients. What about challenges in pediatric dialysis, developed versus Middle East countries? If we look at developed countries, what are the challenges in pediatric dialysis? Regarding number one, growth failure, often resistant to growth hormone, and cardiovascular mortality and morbidity, and mineral bone disease. If we look at our Middle East countries, dialysis facilities are not existent in rural areas where 70% of the population resides. Poverty prevents travel to tertiary hospitals. Vascular access problem, technical expertise. So all these are challenges regarding pediatric dialysis. Now, what about the adverse impact of extended dialysis? Extended dialysis time affect negatively the outcome of graft function. And this study proves this, because if we look at here, we have the duration of dialysis. If it exceeds 24, if it exceeds two years, I mean, those who remain on dialysis more than 2 years, they have the poorest graft outcome compared with those who were transplanted preemptively or short-term of dialysis. So this is one of the adverse impact of extended dialysis. Now, what about deceased donor allocation for children? In the Middle East, we don't have active deceased donor program. As I said before, you can see here, if we look at the whole Middle East, as I said before, 20% of all transplantation were from deceased donor. 80% from living donor. But if we look at those countries, not the whole Middle East, if we look at only at those countries where we have deceased donation program, for example, Iran, Saudi Arabia, Kuwait, Tunisia, Turkey, Qatar, United Arab Emirates, we notice that 30% in those countries, the transplantation are from deceased donor and 70% from living donor. But still, it is far less than what is going on in North America. As you can see here, almost 49% of all transplantation in pediatric recipient are from cadaveric donor. What about the technical issues? It is a big problem, especially in very small children. This is one of the most important challenges in pediatric kidney transplantation, not only in the Middle East, but in the whole world. Number one is the size disparity between the kidney size, because mostly the kidney is coming from an adult donor, the size disparity between the kidney, the adult kidney, and the patient. Anastomosis, also vascular and ureteric anastomosis, intra and post-operative ICU care, transplantation in lower urinary tract abnormalities, especially for kidney, for patient with neurogenic bladder, and retransplantation, because many children nowadays are undergoing second transplantation during adolescence if they were transplanted first time in their less than 5 years of age. What about the post-transplant challenges? Number one, immunosuppression. There are several issues regarding immunosuppression in children. Number one, the internal issues regarding the child, heightened immune response, variable drug handling, immunosuppressive toxicity, susceptibility to infection, susceptibility to PTLD. This is not only in the Middle East, but in the whole world. The external challenges are drug availability, because sometimes the immunosuppression are not available, and the cost and monitoring facilities. So let us look at the immunosuppression cost per year compared to GDP per capita. Here are several Middle East countries. As you can see here in yellow color, this is the immunosuppression cost. In blue color, it is the GDP. GDP is less than the immunosuppression cost in all these countries: Jordan, Egypt, Tunisia, Morocco, Syria, etc. But if we look at rich country like Kuwait, Saudi Arabia, Turkey, of course, in those countries, the GDP exceeds the immunosuppression cost. But the cost is a challenge, of course, in our region in the Middle East. What about the acute rejection rate over the last 3 decades in some Middle East countries as compared to the US? Here we have 2 examples. For example, Saudi Arabia and Pakistan. Fortunately, the acute rejection rate has decreased over the years from 48% up to 17% in Pakistan, and from 31% to 9% in Saudi Arabia. And in Egypt, 32%, one single study. In Oman, a cumulative acute rejection rate in children, 18%. This is from 1994 up to 2015. North America is around 15%. So in North America, the acute rejection rate a little bit less than some Middle East country like Oman. But Saudi Arabia is 9% nowadays. Okay. What about the 2018 report of the Nabretics probability of first rejection at 12 months? As you can see here, from living donor, the acute rejection rate is 12.7%, and from deceased donor is 13.2%. Now, what about minimization? There are many trials that show that steroids are not necessary for low-risk children, as you know. Calcineurin inhibitor may be withdrawn in some children. Monotherapy may be practical in some children. However, in the Middle East, there still exists concern about the safety of such strategy, and minimization protocol are still far from being widely applied and accepted. Now, what about infection in pediatric kidney transplant? Infection is the major killer, as you know, especially UTI, which is the most important infection. Incidence is ranging from 40 to 80%, which carries the increased risk of graft loss, especially those who have urinary tract abnormalities. EBV and BK infection are the most serious. But regarding fungal and parasitic infection, they are uncommon in pediatric patients. What about 1 and 5-year graft survival in pediatric kidney transplant from some Middle East countries? We have certain studies I mentioned here. If you look, the first one here in Iran, from Tehran, 1-year graft survival, 90%, 5-year, 81%. This is from Saudi Arabia, Scott, Saudi Center of Organ Transplantation. 1-year graft survival, 97% from living donor, 96% from deceased. 5 years, 92% from living donor, 83% from deceased donor. Kuwait, Hamid Al Isa Center, 90% 1-year graft survival, 87% 5 years. Jordan, 96% 1 year, 88% 5 years. In Oman, Muscat Royal Hospital, 96% 1-year graft survival, 78% 5 years. Egypt, Cairo, Qasr Al Aini, 1-year graft survival is 92%, and 5 years graft survival is 90%. Sorry, I will have to drink a little bit water. So if we compare this with United States and North American pediatric renal transplant cooperative study in 2018, more than 99% from living donor, and more than 97% from deceased donor, and more than 90% from living and deceased donor, 5 years. What about the growth after transplantation? This is the mean change in standardized height score. I have a few studies regarding the growth after transplantation in the Middle East. I noticed that one important study from Turkey, from University of Gaziantep, we have noticed here that the patient 5 years after transplantation, they improved their height from minus 2.3 up to minus 1.4. That is good. But of course, if we look at the North American Pediatric Renal Transplant Cooperative Study, they have better response, the better growth after transplantation. What about the quality of life and medical non-adherence in pediatric kidney transplant recipient? The immunosuppression side effect has significant impact on quality of life. Adolescents are especially susceptible to non-adherence, as we said before. Poor adherence is the sixth most common cause of graft failure, according to North American Pediatric Renal Transplant Cooperative Study of 2004. Graft loss due to non-adherence is underreported. Sometimes we don't know about, but it is usually miscoded as chronic rejection. But the cause of this chronic rejection is poor adherence. What about the rate of non-adherence in pediatric transplant? We have several studies from different parts of the world. One of them is from Pakistan. Our friend, Professor Adib Rizvi, has reported this. The percent of non-compliance in Pakistan was 7%. It was published in Pediatric Transplantation. In other studies, as you can see here, it ranging from 22%, 30%, 17%, 12%, but in Pakistan was only 7%. So how to overcome the challenges of pediatric kidney transplantation in developing countries? We have a model, very good model for funding renal replacement therapy facilities and transplantation in Pakistan. I have visited Pakistan 3 times, so I am very well aware of what's going on there. That's why I would like to show you what's happening there and how they are overcoming the challenges of pediatric kidney transplantation. As you know, Pakistan, like many other Middle East countries, we have economic constraints and the paucity of renal replacement therapy facilities in the government. And on the other hand, high cost in the private sector. So this necessitated a system where RRT and transplantation could be funded and offered free of charge to the patient with lifelong follow-up and medication. Free of charge. They call it community government partnership model. The model sustained itself for more than 30 years at SIUT. SIUT is Sindh Institute of Urology and Transplantation in Karachi, Pakistan. Certain strategies were introduced to reduce the cost without compromising the quality. They are using basic hemodialytic machine, which cost 30% less than more sophisticated units. In-house preparation of fluid, dialysis fluid, dialysis reuse on automated system, use of generic immunosuppression. SIUT community government model has shown that it is sustainable and can be duplicated. I'm sorry, and can be duplicated and developed in other developing countries. This I already published what I presented now to you about pediatric kidney transplantation in the Middle East. It was published in the Experimental and Clinical Transplantation 4 years ago, which is the official journal of the Middle East Society for Organ Transplantation. So to conclude, incidence of end-stage kidney disease in pediatric population is much higher than observed rates. Transplantation activity are limited by, number one, absence or inactive deceased donor program, expertise and specialized center, and economic resource. The community government partnership model in Pakistan has shown that pediatric RRT and transplantation can be successfully established in a developing country. I have to acknowledge the help and assistance for all those friends from across the Middle East who provided me with the necessary information regarding the transplantation data, especially for children. Here you can see the name and countries. Thank you very much.
Thank you, Dr. Bassam, for your excellent talk and the overview of the pediatric kidney transplant in the Middle East. I will open the floor for the questions. If anyone has questions, please ask. I don't have so many questions on the chat. So if you have questions, please ask.